Hello, everybody. I'm Dr. Petros Grivas. I'm a professor here at the University of Washington, medical oncologist at Fred Hutch Cancer Center. And I'm very honored and thrilled to have a great colleague and friend here to talk about GI cancers, gastrointestinal oncology. And I talk about Dr. Rachael Safyan, who is an assistant professor, soon to be associate, in my opinion. She deserves it here at the UW and Fred Hutch Cancer Center. And Rachel, in addition to the many things she will tell us about, she recently took over from my dear friend, Dr. Gabi Kiorian, as the research director for the GI medical oncology. So, Rachel, welcome to the podcast, Meet the Greek.
Thank you very much for having me, Dr. Grivas. It's a pleasure to be here today.
Wonderful to talk to you, Rachel. And I try to remember, a few years ago you joined us. You came for Columbia in New York. I remember, these days very well. Tell us a little bit more about your journey so far, and how did you end up in this beautiful Emerald City?
It's been a fantastic journey. I am originally from the East Coast, and I had done my college, medical school, and a lot of my medical training back east in Manhattan specifically. But I had come out here to the University of Washington for my medical residency and had stayed on as a chief resident and had the opportunity to spend time over at Fred Hutch, both in the clinics and with investigators. And it really struck me how much providers at Fred Hutch and at the University of Washington really valued patient care, research, and education. And I always wanted to come back and be on faculty. And so I went back to New York for my fellowship at Columbia, and then I stayed on as GI medical oncology faculty. And then when a position opened in 2021 here, I jumped at it after staying in touch with Dr. Kiorian, who's been a fantastic mentor, and really just came on in the spring of 2022 and haven't looked back since.
It has been such a great pleasure to work with you, Rachel. And I remember when you first came, I was talking to colleagues, in Columbia, and also our dear common friend, Dr. Jessica Holly, who also came from Columbia, and they were all saying great things about you. And I am sure I knew and I confirmed over the years they were so correct. So you are incredible. Tell us a little bit, Rachel, about the research you're focusing on and the work you're doing, just to orient the audience on that note.
So as mentioned, I'm now the new research director of our clinical GI Med-Onc group, and so in that space, I oversee a lot of various clinical research projects. My own personal interest is in pancreatic cancer, and I'm involved in multiple different ways in pancreatic cancer research. Interested specifically in novel biomarkers and therapeutics in this space. And there's a lot of great things that are coming down the pipeline on a national level, but on a personal level, I have an interest in looking at particular subtypes of pancreas cancer. One of them is the KRAS wild type subtype of pancreatic cancer. So about 90% of pancreas cancers are KRAS mutated. And probably of the 10% that are wild type, almost 50% of them may have other drivers in the MAP kinase pathway. But this patient population is thought, based on retrospective data and some newer clinical and more recent data, to be responsive to anti-EGFR therapy. And so on a national level, there is hopefully going to be a study activated, SWOG S2433, in November of 2025, where I am the study chair, looking at the addition of panitumumab with or without chemotherapy in the second line setting for patients with locally advanced or metastatic pancreas cancer, again, who are KRAS wild type and BRAF V600E wild type. So a lot of focus in that KRAS wild type space, also looking at, that's really the space where there are patients who are MSI high, a variety of fusions and other actionable alterations where targeted therapies may be appropriate. So that's one very exciting space, I think, of research currently.
It's actually really, really impressive work, Rachel, and congratulations on being the PI in the SWOG trial. I know National Clinical Trial Network, NCTN, it's a great mechanism that I always encourage, junior colleagues and investigators to get involved with cooperative groups. And it takes time and effort and energy, but when the trial is open, it can accrue very fast. So congratulations on that one. It's a great milestone.
Thank you. It's been a very exciting journey, learning a lot about the cooperative group space and the amazing collaborative work with statisticians and patient advocates. Really such a great asset that the cooperative group utilizes. They really, I can't speak enough about how important they are in a lot of work we do, including clinical trial design.
Totally agree. I think the voice of patients is very important. Is for first and foremost in our mind, and I think to your point, Rachel helps us design clinical trials that are patient centered. And on that note, I want to ask you: there's so much work being done here at the Fred Hutch, so many trials, lab work, collaborations. Tell us a little bit about the program that you are leading, taking over from Gabby. It's really difficult to, of course, put it in the next few sentences, but it would love to hear about your thoughts about the program overall and some examples of other clinical trials.
Yeah, so we have a very robust GI oncology program. There's 11 faculty members. A lot of us are involved in clinical trial work. Some of us do health outcomes research. Others are more involved on the laboratory side of things. We have a very large clinical trial portfolio that we hope to expand significantly within the coming 12 months. The clinical trials span anywhere from upper GI, so gastroesophageal, all the way down to colorectal studies. Many of these are industry sponsored, but some are through the cooperative groups. And we have a couple of very interesting investigator initiated trials that are coming down the pipeline. So, speaking of some of the great research that's being done here, so I personally partner with Dr. Sita Kugel. She's an incredible scientist here at Fred Hutch. She has a lab that's focused on pancreatic cancer, but also biliary tract cancers. And some of the work that she's doing is actually going bench to bedside very soon, thanks to support the pharmaceutical company Carrick, who's going to be providing drug and foundational support from the V Translational Foundation, as well as philanthropic support through the Lofgar Family Foundation. And so this study is a window of opportunity study looking at CDK7 inhibitors in patients with the basal subtype of pancreas cancer. So about 25% of patients with pancreas cancer have a more aggressive, more chemo-refractory subtype. So Dr. Kugel's work, which is very novel, is hopefully in the first quarter of 2026 being brought to our patients with localized disease. Um, that's one particular project. Dr. Kugel's lab has many other projects. She's doing work as well with CDK7 inhibitors and biliary tract cancers. She's also interested in how the IL-1 RAP pathway may be involved in the basal subtype of pancreas cancer. So there's data supporting the use of IL-1 RAP inhibitors with chemotherapy in the advanced setting of metastatic pancreas cancer. But it also turns out, based on her work, that HMGA2 high tumors, which really also represent the basal subtype, actually increases IL-1 RAP inflammation. And so we hope to explore that a little bit further and bring that to our patient population here at Fred Hutch, and thinking about other novel ways to bring the CDK7 inhibitors, other combinations to the clinic, as we learn more in the preclinical space about resistance mechanisms to the drug. So what combinations, including with RAS inhibitors, another very exciting space currently in 2025 in GI oncology.
What an amazing portfolio of trials, Rachel, and so much is going on in the field. I get, many calls sometimes, for either from patients, from other countries. And, it's always important to have this outreach, at Fred Hutch and try to take care of our patients and people who come to us. And, pancreatic cancer, to your point, has always been a very hard one with, usually a challenging prognosis. But everything I'm hearing from you here is that there is hope for drug development, more biomarkers to help select patients. So it's a very robust program. And kudos to you and the team for putting that together and helping patients get access to innovative therapies through clinical trials. It's really important. Can you also tell us a bit more, Rachel, about the work? You and me talk about it frequently. How can we work together more with community oncologists? I always admire them. They see so many different cancer types. It's hard to keep up with all of those. And I know you're doing a great job with communicating with them. Can you share a few thoughts about how can we work together and kind of bridge the gap between the Fred Hutch and multiple community sites around there?
I think I agree with you, Dr. Grivas. It's so important to bring our trials out into the community and also to bring awareness so that patients have the opportunities to hear more about these studies, especially as they become more biomarker selected. And so talking and learning a little bit about how do we get testing, tumor testing or liquid biopsies done earlier in a patient's disease course. And then also as we move studies from the metastatic setting into the neoadjuvant space, such as another investigator-initiated trial here where we're bringing a novel immunotherapy combination to our patients in the neoadjuvant space with pancreas cancer in combination with chemotherapy. How do we offer these opportunities to patients before they've started on a line of therapy, perhaps in the community, and see if they might be eligible? And so I think some of the ways we're doing that is we're partnering with our local um, Fred Hutch community programs nearby, really encouraging participation in our research meetings. I'm participating in their monthly meetings. We want to expand our clinical trials more and more to our community sites, especially those phase 3 trials, which are a little bit easier to enroll kind of in the community with fewer blood tests, fewer visits that might also involve standard of care. I hope that perhaps myself or maybe others will be able to go out to those community sites. Maybe there will be a day where we'll be able to see some research patients out at those sites, as I know that some other providers here at the institution can do. And then I think thinking about ways that we can get newsletters out to providers across the states, whether they're in our network or not in our network, um, letting people know, or maybe our colleagues who see our patients and diagnose them, our GI colleagues who are doing these endoscopic procedures. What is the research here? What options do we have? Because we do have novel options for many patients. Many patients still, unfortunately, will not have a trial option for every step of their disease journey. But us being able to partner with the local provider and then finding the right time, the right trial, the right fit for each patient, I think is really critical.
Absolutely. And, giving that opportunity to patients to participate so they can hopefully and ideally benefit themselves, but also, help in the creation of this important knowledge to help other people and other patients. I think it's so important. And you touched upon that already, Dr. Safan, with your great team. Tell us a little bit more about, the multidisciplinary nature of the program. You mentioned, the gastroenterologist, surgery, radiation oncologists, geneticists, nutritionists, social workers. It's a huge team, more than a village.
It really is. It takes it. You said it correctly. It takes a village to help our patients, and I think we surround them with every possible support we can, whether that's supportive care that focuses on their quality of life, like our palliative care providers, integrative medicine, nutrition, social workers, child life, just to name a few. But then also the unbelievable team that we work with that to help take care of our patients with very complex issues, whether that's our interventional radiologist, our GI providers, interventionalists, or otherwise. We have an incredibly robust colorectal surgery program, thoracic surgery program, hepatobiliary program, a brand new HAI, so hepatic artery infusion pump program that's just a little over a year old and the only program of such in the state of Washington, our radiologists, and just to name a few. And so we all work very closely together, whether it's, just conversational through our tumor boards, through our multidisciplinary clinics. I think it's really for the best, for the patient's best outcome.
Very well said. Thank you so much. And, it always amazes me, despite being very busy, I think the team is doing a great job getting people in. I know access is a very important point. Patients are anxious and want to get them going. I think the GI team is doing a great job trying to get people in, right?
I think absolutely. The earlier we can see people, the better it is. And I think we're all very available to see people at any point in time. We're hoping that within a couple days of someone calling and asking for a visit, that they can be seen, have an opinion, and perhaps there'll be an opportunity down the road where we can also have some kind of communication modality with outside providers. Is there a way? It can be difficult for patients to come and travel but they might be willing or able to do so on short notice if there is an opportunity that might be different than what would be done closer to home. Again, maybe a clinical trial or a procedure like an HAI pump. And perhaps there's ways to engage community providers on a doctor-doctor level to get some of those options out to their patients that they can then explain to them. And again, facilitate care and also reduce the barriers to care.
Absolutely. And to your point, actually we're working institutional wide on this phone app that we're hopeful that we'll be able to share with our colleagues and community very soon. That will be a quick stop when you can look at the app and see what clinical trials may be applicable to your patients that are open here at Fred Hutch. And of course, with the right contact so that this can facilitate, patient referrals when appropriate and also remove the barriers, as you said. So more to come on that end. And I'm hopeful that this can help, our colleagues and friends in community. And on that note, we're discussing about the multidisciplinary nature of the care. A lot of discussion about germline testing in pancreatic cancer, both for treatment purposes and also for family counseling. So you're working a lot with genetics as well, right?
Absolutely. So back in 2018, NCCN and ASCO changed their guidelines to recommend that all patients diagnosed with pancreatic cancer undergo germline testing. We knew that that about 10% of patients will have a germline mutation and that taking a family history was inadequate. And so our current process is to refer all of our patients to the genetics team. They're the ones who do the counseling, the screening, and then the follow-up visit. Having said that, we've got a very robust high-risk clinic program. And so for those patients who are diagnosed with a pathogenic germline mutation, we have ways then to get them into a clinic, talk to a provider about what additional screening should be done for other malignancies, as well as who in their family should be tested and at what age they should be tested. And so it's a great group that I know is expanding and becoming more robust, especially as more and more of our patients are found to have some of these hereditary syndromes at younger ages as cancer diagnoses are moving into our younger patient population.
Points, and I agree with you. And I'm excited that one of our colleagues, Dr. Heather Cheng, joined that team in the leadership level. She has been doing genetics for a long time herself in prostate cancer, and now Heather took over as the director of genetics. And I think the vision is to expand the team because, as you said, it's so important and there's so much need for broader germline testing. I think there's a need, for education of the patients, the communities, the families, because you can have an impact in the patient care, but also in prevention, to your point, for multiple different cancer types in both men and women. So that's a great point you mentioned. The other, question I have for you, as I think about, the expansion of the program, you talked about, different types of cancer in GI tract, and you have great colleagues who focus on esophageal, stomach, and colorectal, and liver, cholangiocarcinoma. A little bit comments about that, kind of sub expertise.
Absolutely. So I do have fantastic colleagues to do all of this. So Stacy Cohen is one of our GI medical oncologists who focuses on circulating tumor DNA and is nationally known for some of the work she's done in multiple spaces related to that. So stay tuned for more work that she has done. Dr. David Zen, who's one of our upper GI oncologists, but also an expert in neuroendocrine tumors, leads national clinical trials through SWOG related to neuroendocrine carcinomas. He too has really built up and expanded our multidisciplinary program in neuroendocrine tumors and leads our neuroendocrine tumor board. And a lot of research there. And then in the HCC biliary tract space, Dr. Bill Harris, who's now involved also in the HAI program for biliary tract cancers, Dr. Gentry King, who also works with Dr. Sita Kugel, who I mentioned before, bringing projects to the bedside, and a lot of work there. Both of them very involved in translational work with close collaborations with several folks here at the institution trying to advance care for our patients with that population. So absolutely across the board. And in fact, our multidisciplinary colleagues have a lot of fantastic research too. Dr. Jeremy Sharab, one of our surgeons involved in the HIPEC clinic, is doing work in that space. And so I could go on for a long time to highlight everybody's work. But absolutely, we should have them all on this podcast to share some of the incredible translational projects that they're doing.
Absolutely. I agree with you. There's so much talent and so much expertise and great people. I have to say, everybody's really, really wonderful trying to help the patient. And actually, we're going to have Dr. David Zen, to your point, coming up in a few days. So he's going to talk about neuroendocrine cancers and upper GI cancer, etc. And of course, we'll have to invite the others. It's such a great opportunity to discuss with you, Dr. Safyan. Before we go, I want to, have you say a few words about your vision for the future. How do you see, GI oncology, moving forward, and what excites you most being here, and why it's important for patients to think about Fred Hutch for their care?
So to answer your last question, I think it goes back to why I came here, which is really the mission. It's UW and Fred Hutch's mission for patient care, advancing care, providing a 360 experience for patients. That it's the physical and mental well-being as they go through their cancer journey. And in addition to the research and the incredible science that's being done here. And so I think we really live up to our mission, and that's what drives me day in and day out. In terms of thinking about the vision, my hope is that we significantly increase the number of clinical trials that we have open. Again, as our treatments become more biomarker selected, that means we need clinical trials that allow all comers in every stage of cancer for all of our GI cancers. And in addition to that, thinking about the niche patient populations, even if they're small, trying to improve and advance the targeted therapeutics in that space. My hope is to bring these trials to our community sites, to our Fred Hutch community sites, reduce the barriers to do so, um, break down also the barriers that prevent just providers from engaging with each other, being at each other's research meetings, perhaps again, us going to those sites, not only for CME lectures or for just conversations about care, but also meeting the patients at those sites. Again, getting out into the community so that we can, again, maximize the patient experience, allow them to stay close to home and be treated close to home, but also provide them, when needed, appropriate, unique care that hopefully will give them a better quality of life and improve their survival.
So well said. Comprehensive as always, Dr. Safian. Thanks for all the work you're doing. Thanks for leading the group and taking over from the amazing Dr. Gabi Kiorian. And of course, for being an inspiration, for our patients and colleagues. And thanks to the whole GI oncology group.
Thanks for having me.
Appreciate it. Thanks to the audience for attending this second, again, inaugural still podcast, and looking forward to having you in the subsequent podcast. Thank you so much for your attention and time.